We have with us Dr. Arash Jaberi, who's the division head of vascular and interventional radiology.
I say I have my dream job. I get to use a lot of technology. I get to have a significant impact on patient care.
What are the things should a trainee be looking for when they're looking for a good training program? And in general, are there any big picture differences between training in Canada versus training in the US?
You take on some risk, and it is challenging taking on these complex procedures, and you may lose a little bit of, sleep over it, but you can't really succeed unless you're willing to take risks in IR.
Arash, that seems to always be a significant interest in VIR, in interventional radiology. What was your inspiration?
That's a great question. I was very lucky. I stumbled upon interventional radiology as an undergraduate.
As an undergraduate?
Yeah.
Wow, okay. That's quite early.
Doing research in nephrology, of all things, at St. Mike's.
Okay.
So the person I was doing research with, Dr. Sandra Donnelly, she was the hemodialysis coordinator at the time, and we were doing a project on cephalic arch stenosis. And so, vascular access is a huge part of interventional radiology. And she encouraged me to go down and spend some time in IR. And I did. And I thought, wow, this is pretty cool.
Wow. Is that the one in which they create a fistula, but then eventually they might have some stenosis in some of the veins in the upper arm?
Exactly. So the cephalic arch is notorious for getting stenosed over time. They think it's related to the flows, the angle. So I was investigating that. And I got to work with some really cool interventional radiologists early on, like Vikram Prabhadesai. And then I went on to work with Derek Murdali at St. Mike's. And, those were my initial mentors who kind of guided me through radiology and research, and I went on from there.
Wow. So you had great mentors and you kind of stumbled upon it, but now you are leading your own division, and it's been quite a journey. And I think that you probably have seen different facets of interventional radiology. But what are your overarching thoughts? How satisfying do you think it is? Or how challenging do you think it is? Or how frustrating do you think it is? Or is it a mix of everything?
For me, I always, I say I have my dream job. I get to use a lot of technology. I get to have a significant impact on patient care. I work with a team of interventional radiologists close by, but also nurses, MRTs, at an academic center. So, I think, it's a great opportunity for me. I'm very grateful for that. There's always frustrating things in any field of medicine, but that's par for the course, and those frustrations allow for opportunities to grow. So,
as long as the balance is maintained, the frustration, satisfaction balance is maintained.
Exactly.
That's great. So you say that, and this is a kind of a great thing to notice, because when you said it, you said that, oh, I'm supposed to do it. That's not what you said. What you said is that you get to do it. And it shows how grateful you are, and what a privilege it is to be able to work here and to be able to do the things that we have done. And I'm assuming that things have changed quite rapidly even since you began interventional radiology, right? And what are probably some of the biggest changes which have come during your career?
So, I've been in practice just under a decade, and we've seen a lot of new procedures developed and implemented. Some of my colleagues have actually gone to other centers, learned, and then brought back that knowledge. So, for example, pulmonary angioplasty, Dr. KT10 went, learned, and brought back, and now we have Dr. Malfal taking over that area. There's been significant advances in oncology when it comes to interventional radiology. That's kind of the new frontier. So whether we're talking about ablation, cryoablation, microwave ablation, but also radioembolization with Y90, and a lot of these procedures are being funded by the government now because they're evidence-based.
Yeah.
A lot of my colleagues, like Dr. Kuchera, Dr. Beecroft, have spent a considerable amount of time trying to get these things approved so that we can offer them to our patients in a sustainable way.
So you say that your colleagues have gone and learned and come back, and each of your colleagues is doing a specialized procedure and they offer specialized services. So the way most trainees, and I guess even diagnostic radiologists, we think about it as like intervention radiology is just one umbrella. It is just that you put a catheter, you do the same thing. We kind of think like, oh, okay, it's just like driving. But I think the way you say it is like very different things. One is like driving a bike, the other is driving a car, and the other is driving a truck, and the skill sets are probably different, right? So are these like a whole bunch of procedures just randomly thrown into an umbrella, and kind of what connects everything, and how do you develop skills in different procedures?
So during your fellowship, you're going to develop the foundation.
Mm-hmm.
Image guidance, being able to interpret a CT and plan a procedure, being able to consent patients, figuring out what is the best treatment for patients. And then over time, you're going to develop an area of interest.
Mm-hmm.
And when you develop an area of interest, you're going to spend more time trying to understand what is the latest and greatest in that area.
Okay.
And then maybe even through research, you're going to try to advance that area. So at our institution, because there's so much complexity now in all the different types of cases, we usually have 2 operators who kind of hone in their understanding and their skill set into one particular area.
Okay.
Yeah.
So if you have that foundational knowledge, is that easily transferable to individual procedures, or is training volume like, do you think that the foundational training volume, if there's a lot of volume, then you can pick up any procedure and be able to do it? Or do you need training volume in individual procedures per se?
For complex procedures, you still need to have some exposure to get comfortable.
Okay.
And, some could be variable for different operators. Sometimes it might be 20 cases. Sometimes something like TIPS, probably 50 or 60 cases. So most fellowships don't train you for the super complex stuff for you to do it independently.
Yeah.
Without the guidance of senior colleagues.
Mm.
That is one of the best parts of working at UHN. Even as a junior staff, you have many people that you can rely on, and they can give you the guidance needed to be successful. You take on some risk, and it is challenging taking on these complex procedures, and you may lose a little bit of, sleep over it, but you can't really succeed unless you're willing to take risks in IR.
Do you still lose sleep over some of the procedures you do, or does it get better over time?
It does get better over time. Before I would always spend like significant number of time looking at all the cases I have in the coming week. And I think that shortens a little bit up to a point.
Mm-hmm.
But, you're always one case away from being humbled and being reminded that this is difficult.
Oh, absolutely. Even like I don't do a lot of procedures. I do some minor biopsies and stuff. But even then, and I've heard some of my seniors and mentors say that it's kind of a little bit of a sine curve in which you get confident and then one random complication or something happens and then, your confidence dips. Is that always there, or it kind of flattens over time?
This has been my experience. I was just speaking to my colleague before I came here.
Mm-hmm.
I was doing a tough ablation, and I was telling my fellow, hey, sometimes you need these types of procedures to remind you that the specialty that you're in is challenging. And this is why you go through a very rigorous fellowship to build that foundation.
Mm-hmm.
And that's why you go to courses and continue to learn, and you go to conferences. I just came from the CARE conference, which is our annual interventional radiology conference.
The CAIR.
Yeah.
Okay.
So, that's why you have to go there and keep up those skills and learn from others. I was doing a tips talk, and, I kind of selfishly did it so that I could learn from the other person who was, my co-speaker, because I knew that they had done a lot of tips. So
Okay.
I'm sure they had some stuff they could teach me. And it was amazing because you do learn a lot from just discussing cases with your peers.
That is true that you can learn a lot just from lectures, discussions, and doing research and reading up research. However, isn't it fundamentally very different compared to diagnostic radiology? Because when you're thinking about training volumes for diagnostic radiology, at the end of the day, it is still a little bit easier. Because let's say that I'm not good at reading MRI of the abdomen. all I need to do is just look at all the MR abdomens done last year, which is going to be in thousands. So I have so many to literally just look at and get trained. However, for IR, because you're supposed to be doing, you're supposed to have hands-on skill, isn't training a little bit more tougher because the logistics of it doesn't allow you to do a lot of these procedures? And so how are training programs structured and built, and how do you kind of overcome that?
So yeah, to speak to your first point, getting those cases takes time and it's very difficult to plan that out unless you spend time at a very busy fellowship.
Yep.
So you don't have the luxury of just looking at, a bunch of film in the past, though again, there are opportunities to study procedures that have already been done and understand the rationale why somebody did one thing versus another.
Okay.
Look at the report, see if there's any complications. So you can still take advantage of some of the same things you have in DI. But the hands-on is ultimately the most important, and you can't get that retrospectively. You got to get that prospectively.
Okay.
In terms of the structure of our program and education in IR as a whole, you do a 5-year residency in DI, and then you go on to do a 1-year fellowship in IR. And I think that's kind of the standard. We still have that. Mm-hmm. Lately, though, and more recently, we've had subspecialty designation and created IR residencies.
Yes.
This was kind of led by our colleagues in Quebec, where they established the first interventional radiology residency program that was approved. Then we went on to be one of the, if not the first English-speaking fellowship-approved Royal College IR residency. However, it takes a long time to implement. There are a lot of nuances in terms of implementing an IR residency, and also we were going in at the same time of CBD. So
the competency-based design.
Yeah, exactly. So this also made it a little bit more challenging for us, but we are enrolling our first 2 IR residents this year, starting in July, even though the residency was actually approved a few years back.
Yeah, that's amazing that they're starting right now. I do understand that, especially given all these complexities, it takes time to structure and make sure that everything is satisfied, because at the end of the day, it's a very delicate balance, right? Despite being an interventional radiologist, a good diagnostic base is still required. So structuring that, of course, takes time. So how is it currently structured? Is it going to be a 5-year program, or and does it have like surgical training and diagnostic training? Like, can you give more insights as to?
Sure. So it's a little bit different than the American IR residency programs. Mm-hmm. They have a direct entry from medical school, from my understanding. We still require applicants to get into DI, complete DI, and in their 4th year, they would still apply for a place that offers an IR residency and perhaps a fellowship. So if they are selected to be the IR resident, they would spend their 6th year of training as an IR resident. It's really a 2-year program where the first year is double counted from blocks that are in your in your last 3 years of DI residency.
Okay.
So it doesn't actually extend your training. You're still getting trained for a total of 6 years.
Yeah.
It's just that the 2nd year of IR residency is that 6th year. And it's an accredited program that requires you to conform to everything the college expects from a residency program.
That's very interesting. So I guess you still have the option of going through diagnostic radiology and still figuring out if this is the right fit for you.
Yes, I actually think that DI residency is critical for any IR. I wouldn't want to separate from DI. I think that DI gives you the foundation, and in order for you to be a good interventional radiologist, you also have to be a good diagnostic radiologist.
So I understand that you are an amazing diagnostic radiologist as well, and you do kind of mostly intervention, but you still also keep up your skills in diagnostic. What in your mind is the biggest difference between the two?
Well, I still consider them both equally challenging. So it's not that. It just, you have more patient interaction direct patient interaction in interventional radiology, but there are also other areas of diagnostic radiology. For example, the biopsy center where you get to, interact with patients,
yeah.
or in breast radiology, you have a lot of contact with patients.
Mm-hmm.
But if I have to say that, if you're sitting in front of a screen, you're not going to be speaking as much to patients directly. So that is a big challenge. For most diagnostic radiologists, they're not coming into the hospital at 3 a.m. in the morning, to deal with an acute patient.
Mm-hmm.
That's probably slightly different.
Yep.
But again, there are many diagnostic radiologists who are working very long hours in the middle of the night.
And you still get woken up in the middle of the night to look at an ischemia, which if you could potentially do at a laptop from your place instead of having to drive to work to kind of fix that said ischemia with a thrombolytic agent, I guess.
And the lifestyle of all radiologists is actually kind of, I would say, maybe different than in the past, because there's more and more expectations to have final reports by staff. And there are many sites in the GTA that have specific emerge radiology programs where they have staff reports being done as if it was during the day.
It's a 24/7 specialty now.
Yes.
You're always expected to be on call. No, you don't get a minute of break. If you're walking to get coffee, you get 3 different phone calls and 5 different emails for something which are going on.
Absolutely.
As regards the training itself, now, I understand that here it's still structured that you still go through DI and then you decide whether you want to be an interventional radiologist or not. What are the things a trainee should consider before making that decision in your mind? What are the factors should he evaluate? Or do you think that VAR is the best, everybody should try and get that? Or do you think that there are certain factors which make some trainees better at VAR than anything else?
First and foremost, you have to spend some time in the IR suite to see if you like it.
Mm-hmm.
There are many moments in IR where things are a little bit more stressful.
Mm-hmm.
You have to make decisions quickly, and you have to be comfortable with sometimes not getting the best outcome, but trying your best.
Okay.
It's always, I think it's good if you like to be competitive, not necessarily with others, but with yourself, right? You want to do a case and you do it the first time, and then next time you want to do a little bit better, and you see
absolutely
how can I compete with myself to be a better version of myself to give the best care to the patient. And so there's lots of opportunities for that, because you often do the same procedures over and over and over again. You have to be comfortable with doing some, physical work. You're going to be wearing a lead apron.
Oh, yeah.
So that's 40 pounds that you have to carry all the time. And
better hit the gym, and you look in great shape.
But you do have to be able to tolerate that. It does weigh you down. After a long day, you feel the lead more and more. I mean, at least I feel it more and more, but I still, it's not a big thing for me. And I think that if you can't tolerate that, it probably won't work, because we do use, radiation for a lot of things. Not everything, but a lot of things. Some people say if you play video games as a kid, you tend to do better. And these surgeons probably have the same relationship or correlation.
Did you play video games when you were growing up?
I played a lot of video games.
Okay.
A lot of Nintendo, probably too.
Not Nintendo, yeah. That's the secret, guys. Play Nintendo.
Mario Kart, that kind of stuff.
Yeah, so I understand it can be really, really stressful. But we recently, I heard that you've renovated your IR suites. There is all these colored lighting and mood lighting and everything to make life as peaceful as possible. How's the renovation going on?
Yeah, so we're super excited about that. We had to completely renovate or replace our angiography units at UHN, both at the Toronto General site and Toronto Western. We ended up going with Canon, and slowly but surely we are making sure that the units are being placed and the quality is top-notch, and we're able to provide the best care for our patients at UHN. We have CT fluoro hybrid suites, two of them at Toronto General, one of them at Toronto Western, which is, is such an advantage. Being able to have ultrasound, fluoro, and CT in the IR suite for any case at your request.
Yeah, it opens up a lot of possibilities, right?
Right. And then you also don't kind of slow back your DI colleagues where you have to, share a room and they have patients that they want to scan. And and the wait lists in radiology are so long. So by us being kind of isolated, we can focus on the stuff that we need to do. And we're super excited to be working with Canon. We have a very good relationship with them in terms of the research that we're going to be doing with them. And they've been supportive in making sure that our equipment gets set up right.
Perfect. And in terms of training, I heard that you're also bringing in more technology in training with these fancy glasses and stuff. Can you tell me more about that?
Yeah, we want to be cutting edge, not only in the procedures that we do, but also in education. There's a group of us who are very passionate about our educational program, our fellowship program, and our residency program. So we have stuff like the glasses that are going to be coming, and we're going to be looking at different types of procedures that we can share perhaps with online and use it as an educational platform. So junior trainees or even medical students can look and see what we do and perhaps learn from the videos that we make and hopefully be able to implement that into their own practice.
So these are glasses with video recording on real time so that you could stream, you could save them for teaching and...
so develop teaching files and maybe have, a YouTube channel that people can tap into and say, okay, if I want to learn how to do a port insertion, this is one version. And, there's so many ways to do a procedure. Little steps may be different. So hopefully we'll have multiple operators that are doing the same procedure, so there's no one way.
Absolutely.
Yeah.
Because I understand that, especially with procedures, there is a style and there is no right answer. One technique might be better than the other, but then everybody develops their own unique style, each of them with their own nuances, and they may all be equally effective or maybe effective in different situations as the need be.
Exactly. And I think one of the advantages of our fellowship is that we have, 12 different interventional radiologists, and the fellow will have to go and figure out, okay, this is how one person does it. This is a different way that someone does it, but the same end result, they get a good outcome. So we hopefully will be able to do that for our educational videos as well.
That's perfect. In addition, I was speaking to Dr. Maffel, and he was saying that you're using VR glasses as well for the patient side of it, so that the need for sedation is not that high, and also they feel much more comfortable during the procedure itself.
Yeah, so Dr. Maffel did that wonderful study on VR access to patients during the procedure, even perhaps after the procedure is something that they were going to look at.
Interesting.
Patients are asking for it. It's so good during the procedure, they want it after.
That's amazing.
But, I think everything when it comes to the patient experience from the moment they enter the hospital to the moment they leave, is something that we can optimize. Hopefully there'll be opportunities to use funding, from donors that will be able to make this experience better for patients who are going through a difficult time.
IR seems such an amazing specialty. What are the commonest misconceptions about IRs that you've ever heard or encountered, or commonly you hear from trainees and then you have to correct them?
That's a good question. So I guess one misconception maybe is that we're predominantly a procedural specialty and we don't have that clinical component, where we have our own patients, where we admit our own patients. This does mean that you have to spend a little bit more time in the hospital, but it does give you more opportunities to be clinically relevant. We spend a lot of time working with our colleagues on tumor review boards or MCCs to figure out what is the best care for the patient. And there's the diagnostic radiology perspective, but often, in the audience, beside the surgeons, there's going to be interventional radiologists who are presenting their own patients. And I'm sure you're kind of familiar with that with HCC rounds, right?
Absolutely.
Where
It's
there's
CCs and RCC.
yeah, there's just so many therapeutic options, and you're not alone as an operator. You can bounce ideas off your colleagues, and you can come to a consensus on what is best for patient care. So people may not know that about interventional radiology, that we have this clinical component beyond the procedural component that is critical for our success.
That's perfect. The other thing which actually strikes me a lot is that the common way or the common stereotype is that diagnostic radiologists are think first, think next, and act never, whereas interventional radiologists are like act first, think later. But from the way you put it, there's such a lot of decision-making process, not just in choosing patients, not just in selecting the right modality, but even during the procedure as to how to do a procedure and what are the various pathways you can take and how to personalize the procedure for the patient. So it looks like it's a lot of thought process in addition to having that physical dexterity to do a hands-on procedure really well.
Yeah, absolutely. I once heard that, it's much more difficult not to do a procedure than to do a procedure, right? And knowing when to stop, for example, in a complex case, right? Not aiming for perfection always, going for what is a good outcome that's going to keep the patient safe. You can always come back again to a case if you need more time. So those attributes are sometimes overlooked, but over time you realize that they're very critical.
So I understand that there are so many things which need to fall in place for someone to be a great interventional radiologist, right? So they need to be, really good and strong to be able to carry that lady print the whole day, have the physical dexterity, have those fine finger and arm movements, have an intuitive 3D sense, but in addition, have strong decision making as well, which means that all of these attributes need to be groomed. And I'm assuming that mentorship is kind of very, very crucial for all of it. And you alluded to a lot of mentors which you had. But how do you deal with, now that you are the division head, how do you deal with mentoring your own trainees? And how do you identify trainees who are good earlier? Do you, once they walk in a room, after a couple of procedures, can you tell, okay, this guy's not going to be good in IR and this guy can be good? Or is it something that you can develop the necessary skills for any training over time?
Yeah, so mentorship is absolutely critical. I wouldn't be where I am today if it wasn't for the mentors I had throughout my training. Most of the time, I find that mentorship is most successful when it happens organically. You have an interested learner and you have an interested potential mentor who can foster an optimal learning environment. So that's kind of how my mentorship experiences have been. It's very easy to identify somebody interested in IR. They're the first one there, last one to leave. They're the ones asking you the questions. They have a good foundation of knowledge before they enter their rotation. And then, they're asking to do more during the rotation. So fortunately, we've had a ton of amazing U of T radiology residents who have come through our program, and then we see them in their interested phase, and then we see them in their doing phase. And it's been great.
Yeah, so as you point out, some of the best trainees are the ones who are super interested. They're the first to come, first to leave. And I think that also embodies an interventional radiologist, because if the first case is at 8, you're probably there at 7:30, talking to the patient, making sure everything's set up the way you want to. And you're probably the last to leave because you want to make sure that after the procedure, the patient's doing well, and touch wood, hopefully there's no complications. But once in a while, you do have complications, which you're then dealing with, calling the physicians and all that stuff. And it's been more recently that we talk a lot about burnout as well as work-life balance. And it seems that most trainees, even before they jump into a specialty, they really want the work-life balance quantified at the end of the day. what would your answer be to that when a trainee is asking you, hey, is there a good work-life balance in VAR?
So in radiology, you have a lot of autonomy in terms of what you want your practice to be like. And an interventional radiologist who works at UHN Mount Sinai will have a completely different work-life balance than somebody perhaps who's working in a rural IR center. So there are sites that, for example, don't have IR call, whereas we offer 24-hour calls. So, that impacts your quality of life. And I'm sure it's the same with DI. There are some centers where you have coverage overnight from a different service, whereas there are places where now you're on an emerge shift overnight. So I would say that I always tell trainees that it's up to you in terms of how you want to, in terms of what you want from your work-life balance. If you're okay with spending more time in the hospital, and that's what's going to allow you to do the more complex procedures, well, that's for you. But at the same time, you can still do IR and work with your hands and then, spend a little bit less time in the hospital, but you probably have to work in the community as much. So I don't think interventional radiology has a bad work-life balance, even in an academic center, because you're doing something you love. So when you're coming in at 3 a.m. in the morning, it might be tough initially, but once the adrenaline's pumping and, the patient's there and you're speaking to the family and you're able to use the skills that you developed over many years, it's very satisfying to be able to go back to the family and say, hey, listen, we were able to save your family member's life. So those things get you up in the middle of the night. So it's not that difficult.
That's amazing. That moments of satisfaction, that feeling that you've done something which is really valued by the patient's family in terms of keeping them alive or taking care of some of the complications for them. I think that those offset those frustrations which you might have having to wake up at 3 a.m.
Yeah.
And I guess it all comes down to, once again, how you look at the problem. If you truly love what you do, then I guess that working doesn't feel like work. It just feels like you're doing something which you're really passionate about. And speaking about passion per se, I've heard people say this, that sometimes during procedures, they kind of enter a flow state. Does that happen? Or you're still like first day driving a car, you always feel like very nervous and alert?
Yeah, no, I think it's very important to get into that flow state. It's, a state where you don't have to think about necessarily everything because everything is happening more naturally, and you get into your comfort zone and you stay in your groove. And it does take a while to be able to get into that state when you're really anxious and doing those preliminary cases. But over time, it becomes easier and easier for you to get into that flow state. You do have to kind of have a pattern that you follow. That's why, people are very particular, for example, in terms of, the equipment that they use, the patient positioning. And these things, because they have a pattern, they keep doing it over and over again, it allows them to get into that flow state and really focus on the critical steps, the more challenging steps of the procedure, and avoid those complications that we all want to avoid.
Okay. I kind of completely get it, because sometimes even when doing these biopsies, they change the needle and a new batch of needle comes in and something feels different and you'll never get into that again. So it's good to have newer ones, but it often throws you out, and then it's kind of like getting that recalibrated again. Especially, I'm assuming, for all these catheters and stuff, you deal with that quite a lot.
Yeah, well, I mean, throughout COVID, we had a lot of changes in our supply chain.
Oh, yeah.
Right? So we had to get familiar using different products. And again, the way you need to phrase it is not necessarily a problem, but a challenge.
Absolutely. Yeah.
Right? And as soon as you have that mindset, then it becomes a much more positive experience. And in the end, what happens is that now you have the ability to use a different catheter and do the same thing.
Yeah.
So your knowledge is increased, your skill set is increased, and most importantly, your confidence is increased. So then, it just has a snowball effect where you continue to do great things by believing in yourself.
Absolutely. So now you're not limited by the equipment. You're like, anything in my arsenal I can still use to get the same job done.
Exactly.
Perfect. In terms of fellowship per se, let's say that someone's really interested, where would you suggest that they get trained? I'm obviously going to be biased towards UHN, and I guess so would you, but what are the things should a trainee be looking for when they're looking for a good training program? And in general, are there any big picture differences between training in Canada versus training in the US?
That's a very good question. So I think first and foremost, you want to do high volume and a breadth of different cases.
Okay.
So you should probably look at a center that has both vascular and non-vascular intervention, has interventional oncology, which is the new frontier of interventional radiology. And you want to go to places that do complex stuff. So, for example, a liver transplant center, right? Being tied to a large oncological center like Princess Margaret Hospital. The volume is probably the most critical thing, because at the beginning, you need that repetition. That repetition is going to build that motor memory, right? And it's going to give you the confidence that you need. And there's a lot of variability in anatomy from case to case. So each one of those will be learning opportunities. In terms of the training in the States, I haven't trained in the States.
Okay.
But, I would advise people who are interested in going anywhere, whether it's Canada or the States, you want to look at a program that has the volume and has the breadth. And if you can get that in the States or in Canada, that's where you should go.
That's perfect. And with all the changes coming in terms of at least diagnostic radiology, we talk a lot about AI replacing jobs, or how is it going to enhance the workflow of radiologists. What are the biggest changes you see in the near future in interventional radiology? And do you think that Jeffrey Hinton's quote about stop training radiologists because, we don't really need them anymore, does that still apply for vascular interventional radiologists as well, or that's just purely for diagnostic radiologists?
Well, I don't think that applies in my lifetime, hopefully. I think it'll be a while before we have robotics and, autonomous AI that is able to make all the decisions without any human oversight. I think we're quite a ways from that, but it doesn't mean that we can't use AI as a tool. I'm kind of watching on the sideline a little bit with my popcorn, trying to figure out exactly what's going to happen too.
So what does your crystal ball say?
And I don't know. I think AI will be very helpful. I don't see it necessarily as a threat. Maybe I'm an optimist. I don't know. I try not to worry about too many things, but, in the future, maybe there's going to be AI that helps us pick the perfect stent in a patient, providing us the evidence right there at our fingertip and say, okay, well, based on all the reviews, in the past, this is probably the best device to use in this patient.
Or it might even 3D print the stent based on the anatomy right there on the table and give you custom make a catheter for you right from scratch.
Exactly. Yeah. So, there's opportunities like that, but as of this point, I haven't seen too much practical application of AI on a day-to-day basis.
Okay.
And I hope to, at least support that type of research at our institution so that, we can be leaders, because we do have the volumes and the interest and a lot of keen interventional radiologists who want to be at the forefront of these types of things.
Absolutely amazing. It was a great conversation, Arash. I learned a lot.
Perfect.
I think that with diagnostic radiology, there's always this concern that AI may be taking our jobs away. However, the way I look at it is that it's making healthcare better. But where healthcare is still dependent on humans is vascular interventional radiology. And maybe there is a way to automate it so that, similar to driverless cars, maybe it will do a better job than humans. But for now, we need a lot of young minds to jump into VAR, because your volumes are expanding as well. You're doing a lot more procedures, a lot more types of procedures. So we need a lot more people, lot more enthusiastic trainees coming in to do those procedures, but also find a way as to how they can be automated with AI in future, so that eventually we deliver the best outcome for the patients possible.
Yeah, I also think that we need to do better at letting other patients know about the services that we offer.
Absolutely.
So we need to find opportunities for fundraising. We need to find a champion in IR. You know, we need that donor who wants to support one of the best areas of medicine. You know, that's really technologically driven.
That's amazing. And let's try to bring the word out. And for all who are watching, it's an amazing specialty. You'd be amazed if you didn't give it a try. And thank you very much, Arash. Thanks for your time.
Perfect. Thank you so
pleasure.
much. Perfect.